Okay, so here we are with the study designs. So, study designs basically this means the research design. Okay, because whenever you intend to do a research, it has certain steps. Okay, it has a procedure, and we have different methods of doing it, and it all depends on a lot of factors. So that's why it's important to identify the study design. Okay, which you can choose for your study. Okay, okay. So all the epidemiological studies, they are divided into analytical and descriptive. Okay, and then analytical are further divided into experimental, quasi-experimental, and observational. Okay, and then this observational is further divided into cohort, case control, case cohort. This is same actually. So cohort, cross-sectional, and case control. Okay, three things basically. So we are going to discuss the most common of them. Okay, because these ecological studies, these are just the types of experimental and quasi-experimental. Okay, and individual studies are those which are done where the one unit is one person. Okay, and ecological means when we do we take group as one unit. Okay, whole group. Okay, so here again, the different types of studies. So we are interested in basically here experimental, quasi-experimental, and we will then discuss the observation. Okay, the types of observation. So first of all, descriptive and analytical and descriptive. What does it exactly mean? Okay, all the descriptive studies means you will take the data and just describe it. Okay, this is like just going to a community, collect the data about their disease and explain the pattern. Who is suffering? Okay, like which age group maybe, or which gender is common in which gender. So you can say descriptive is basically the distribution of the disease in a community plus the magnitude. How common is the disease? Okay, so we describe the magnitude and distribution of a disease through the descriptive studies. Okay, we describe the data, whatever we get. The second type is analytical. Analytical means when we also are interested in finding the causative factors or the risk factors of that condition. Okay, so that is analytical, needs a lot of efforts actually. It's not just to collect the data and describe it, but we analyze it through a procedure. Okay, we have analytical, different types of statistical methods to analyze it. Okay, and then what will be the result in analytical studies? We have more information, like beyond the magnitude and the patterns. Okay, like we can say that what is the causative factors and what is the risk factor. It means when we know that the 2 points in time, when the disease starts with a positive factor and when it ends in certain thing, like maybe recovery or maybe death or maybe other prognosis. So all this distance between positive agent till the end, this basically called the causative relationship, like the disease. Okay, or just forget about the end, but you can say starting from a positive agent till the disease is developed. Okay, so which cause is which risk factor is leading to which disease? Causal relationship. Okay, so by analytical studies we establish a causal relationship between the cause and the disease. So now we know the points from where it is started and where it ends. Okay, so causal relationship, which is the cause, or you can say in other words, what is the cause and what is the outcome. Okay. So yeah, this is important. Now these descriptive studies, most of the time we use to identify a problem and generate a hypothesis. Okay, and then we test the hypothesis by the analytical studies. Okay, most of the time the baseline studies are descriptive. Okay, we just find the data, like we just go to the community and find out which diseases are common, for example. Okay, and then then once we have identified, for example, if we go to the community of Vanessa and we have based on our data we identified that diabetes type 2 is common. Okay, type 2 diabetes is common there. So now we will develop some, we identified in, for example, that it's common in the, for example, it's common in the old age, okay? Old people of Onesa. Now we want to see whether this is the causative agent and this is leading to this or not, okay? For example, my hypothesis based on my data is this old age is causing this diabetes, okay? So now I have to test it, okay? For testing it, I will go for the analytical study, okay? So some of the hypotheses, even though this hypothesis is not right, which I just said, okay? Just an example, okay? So any hypothesis based on your data, you test it through the analytical study, and then you will find out that whether it was right or wrong, okay? So causal relationship by the analytical study, okay? So most of the time, the descriptive studies, they precede analytical study, means comes before, okay? Okay, so quantitative studies, so the other way of dividing the study designs is quantitative and qualitative, okay? So quantitative studies are further divided into observational and experimental, okay? And this is most famous classification, by the way. This is shortest one, and this is complete reduced. So we are going to discuss this classification, okay? Quantitative further divided into observational and experimental. Then the second is the qualitative study, and third is the systematic reviews or meta-analysis. Okay, so all of this we are going to discuss. Okay, so first of all, we will start with the quantitative studies, and this whole session, the first session is all about the observational studies. Okay, so we are going to discuss different types of observational studies: cohort, case control, and cross-section, and case series and case control. Then we will go to the experimental and the others. Okay, so let's first, if something confuses you at any point, you can ask me. Okay, because this is very important. You have to use it in, like I told you, not just in this course, but it's important for the coming course like CDM, and then you have research course in MD3. Okay, most probably the first course of MD3. Okay, so you have to apply. Okay, so what do we mean by experimental and observational? So it's very obvious from the name. When I say observational, what do you think? Observation means just observe. Okay, somebody is observing something. Okay, experimental means when we do something, some intervention is introduced. I'm not just observing, but I am doing something with that population. Okay, manipulation or the intervention, or manipulation or intervention could be in the form of any type of, like it could be therapeutic, it could be preventive. Okay, preventive, if I introduce in the population like new vaccine, for example, okay, to test it, to see if it's working or not, okay, or treatment, therapeutic, okay, any new drug I'll introduce in the population, okay, or it could be a new habit also. For example, if a community, in a community, I just introduced them to wash hands to prevent certain diseases. That would also be an intervention, okay, because I told them to do something. Okay, that's something, that intervention of manipulation is called experimental. Anyway, by anyway, okay, it's not, if I'm just observing it, doing nothing, then that would be observation. Okay, this you have to keep in mind. This will be further explained. Okay, what else? This will be our second session, so it will be explained. Okay, so in this session, specifically we will focus on observational study. Okay, observation, like I said, the investigator will just observe. Okay, first type is the cohort. Sorry, take that. Okay, so cohort study, and the other name of this cohort study is prospective study. Okay, so whenever prospective study is written, you have to understand that this is the same as the cohort study. There is no other possibility. Okay, then we have retrospective study, the name of the case control study. Right? So it's not specified. Okay, only retrospective is written. You have to understand this is case control. Okay. Then we have cross-sectional, and then we have the case series and case control. So here the investigator will just watch. Okay. No control over the treatment or exposure. He will do nothing. Okay. So first of all, cohort studies. Do you know what does cohort mean as a word? Have you heard this word before? Cohort. Okay. Cohort is basically a group of people. Okay. Any group of people who has something in common. We call that group as cohort. Okay. That group with us something in common. I'll tell you what is that something. Okay. That something could be any characteristic. Like if they are born on a certain year or certain date, okay, in that case we will call them birth cohort, okay, or maybe they have started something at the same point in time. Like for example, they have joined some organization, or maybe they were diagnosed with a disease at a certain point in time, like in year 2024. Okay, we will call them inception cohort. Okay, it's written on the second slide also. Okay, and then the third could be exposure cohort. Okay, exposure cohort means the exposure was started at the same. So they share something in common. On the basis of that thing, we label them. Okay, like for example, but first of all, just let me see if everything is covered here. Okay, so this is So cohort study, I'll give you the examples afterwards for all those. Okay, so cohort basically is a type of longitudinal study. Longitudinal means which goes ahead. Okay, which goes ahead. That follows research participant over a period of time for many years. So this is something which is specified for a cohort study. It goes, what you can say, from present to future. That's why we call it prospective. Prospective means going forward. Okay. So prospective study is the same cohort study, and what we do in this study, basically we take a cohort and we follow those people over a period of time. Okay. Like for example, I have selected 100 people, 100 smokers from the UNESA, and then I follow them over the period of 10 years, for example, to see if they will have the lung cancer or not. Okay, I'm starting from a point and to reach to certain point. Okay, in forward in time. So that is prospective. The second thing is like the point where I'm starting will be called the exposure. Okay, we are starting with the exposure. That smoking is the exposure. Okay. And the disease, lung cancer, would be our outcome. Okay, so it means cohort study will always go from exposure to outcome. This you have to register in your mind. Okay, exposure to outcome. This would be always a cohort study. It will always start with the exposure. Those people will be disease free. Okay, they don't have the disease at the start. Okay, we follow them over a period of time, and then they develop certain disease. Okay. And most of the time those diseases takes time. Okay, like lung cancer will not occur the second day. It will take time, maybe 20 years, 30 years. So we have to follow them over a period of time, which is most of the time very long. Okay, and it's not like we will just go to the people and just register them, and then after when they develop disease we will visit them again. No, we will visit them at the intervals also in the between. Like for example, I said. Smokers, we collected the data, we took them as the participants. At the second point, then I'll go to them after maybe 6 months. Okay, after further 6 months. So this is called follow-up. Okay, after every 6 months I have the follow-up till they develop the disease, like till 10 years. Okay, so the second characteristic of this study is the follow-up. Okay. It always goes from exposure to outcome. Second is it has the follow-up. It will always have the follow-up. Okay. Okay. What else? The cohort recruit and follow the what I've already told you. Okay. Cohort outcome of the disease field. This I already told you. And the exposure, they will be disease as the birth cohort. Okay, for example, I study on the for example, we want to do a study of the fetuses, all the fetuses who are born to a diabetic mother. Okay, gestational diabetes. All the mothers who has the gestational diabetes, we want to do the study on their fetuses or their children. Okay, and we will start it from when they were born. Okay, and the common thing among them was their mothers were diabetic. Okay, they had the gestational diabetes. Now what we want to see whether they will develop the childhood obesity or not. Okay, so we will follow them until they will develop it. Or some of them will develop, others will not, of course. So we want to see how many of them will develop. Okay, so this would be the birth cohort. Then we have the inception cohort. Inception, like I told you, they have starting something in common which they started with. Like for example, I gave you the example of diagnosis. Okay, so diagnostic cohort would be like if if the people who were diagnosed as having diabetes during the year 2025. Okay, so that would be a cohort. All the people who are diagnosed in the same year. Okay, then we will follow them to see when they will develop the complications. Okay, so forward in time. Okay, from exposure till the disease, and we follow them up, and they were disease free at the first point, right? We started with exposure, right? All three conditions are satisfied. Then we have the exposure cohort. Exposure cohort is like example is given here. It could be radiation exposure, it could be asbestos, it could be any exposure. Okay. So here, like for example, asbestos most of the time is associated with lung cancer. So we can take the people whoever is exposed to the asbestos in a certain factory. Okay, they are working in industry or factory, and they all are exposed to the asbestos, for example. Okay, so now we will follow them up for a certain period of time to see if they will develop the disease or not. How many of them are going to develop or not. Okay, so this could be an example of the exposure cohort. This is clear? But it's not like always we will have one of them. It could be anything. Okay, cohort will share a certain thing, but those certain things will not only be. It could be anything. I just gave you the 3 examples, right? So this you have to keep in mind. Okay, so here it is like cohort. We divide them into exposed and unexposed on the basis of the exposure, whatever it could be. Then we will follow them over a period of time till they develop, and we will see how many of the exposed develop the disease or not develop the disease, and how many of the we call them controls. The unexposed will be controls. Okay, so controls, how many of them develop the disease or not develop the disease at the same period of time. Okay, we will follow them with the same. Okay, so here you can see onset and time. It's going forward. Okay, so this picture is if we will give you this picture, you can identify it, right? You can identify this study. Okay, so then we have the okay, so at the baseline, first observation point, subjects are all disease free. Exposure is used to classify the subjects into exposed and unexposed groups. Subjects are followed to document the incidence. Incidence is new cases, I told you that, right? So whenever if we are starting it from today and we are following a certain period of time, there will be new cases, of course, right? We are not including the previous cases. If our study starts today, okay, so forward. If our study started in 2024, right from that point ahead, it means new cases. So can we call this a study an incidence study? Yes, because same concept. Okay, so it means there are 3 names now. Prospective study, cohort study, incidence study is the same thing. Okay, so whenever these names are used, you should identify this is the same thing. Okay, okay, more than one observational point, I told you, that is the follow-up. Okay, so more than one. So all these conditions are included in the cohort studies. Anything confusing till now? Okay, so now advantages. Okay, what are the benefits of this design? Efficient for studying rare exposures. Because for the rare exposures, this is the only way. Because we are starting, our starting point in the cohort studies always is the exposure. Okay, so if the exposure is rare, it's not common. Of course, this is the most efficient way. our study. We will choose always, if our exposure is rare, we will always go for the cohort study. We will not choose any other study. Okay? The reason will be clear when I'll tell you the other types. It's not possible by other types. Okay? So here you have to keep in mind rare exposures. Example could be exposures, rare exposures. It could be anything like which is not common in what you can say. A lot of examples actually. Like smoke maybe. People who are exposed to the smoke, because the smoke is not very common in the world. It's only it occurs. This is a phenomenon which occurs in only few cities of the world. So maybe like that. Okay, something which is not common. Okay, so if you want to see rare exposures you want to follow, they always choose for the cohort studies. Okay, maybe you used to study multiple outcomes. Yeah, this is the thing. Sometimes we start with we have a hypothesis in mind. Like for example, my hypothesis is smoking leads to lung cancer. But when my study ends, I follow them up, and then at the end of the day, I found out that it's not just the lung cancer, but some of them have developed some certain other conditions also, beyond my expectations maybe sometimes. Like bronchitis could be, other things could be, because always, it's not like always smokers will have certain one condition. They could have a lot of conditions, okay? Bronchitis and COPD and a lot of, so I could have a lot of outcomes, okay? Whether I'm expecting or I'm not expecting, okay? Sometimes this happens, most of the time. Okay, so minimizes the recall bias, yes. Because here, recall bias means memory. If you will ask somebody something, for example me, all humans have recall bias, okay? Like for example, if you will ask me about yesterday, I remember well. I can tell you, maybe the chances that I will tell you the truth, the thing which happened exactly. But if you will ask me what happened 10 years before, maybe I forgot. And maybe sometimes it's not very clear what happened exactly. Okay, so there is a recall bias. If I recall back, there are biases. And more is the duration, more are the chances that we forgot. It's not exactly what happened. Okay, so here there is no recall bias, because we are not asking the patient or the person what happened in the past. We are following them in the future. We are seeing it by our own eyes what is happening. Okay, observer is the investigator himself. So there is nothing to ask them. We just see it with our eyes. So no recall bias. Okay. Then we have allows for the calculation of the incidence of diseases in exposed and unexposed. Okay, so whenever we are able to calculate the incidence, the new cases, the thing is like everything has happened before our eyes. So we can assure as an investigator that this is the cause, this is the effect. Okay, you cannot go you are not confused anymore, because you have seen it, you have followed it for 10 years. Now you are sure that it was started with the smoking and ended with the lung cancer, right? So, and you followed it up, you have evidence, right? So it means you can say with certain, what you can say, the evidence is strong. You can say that this is the starting point, this causes this, okay? So a causal relationship, okay? Incidence can be calculated. Incidence is relative risk, which we will see. So incidence among the exposed and incidence among the non-exposed we can calculate, okay? And then we will divide it and get the relative risk, which we will see, okay? So incidence we can calculate, because all the new cases are happened in front of our eyes, okay? So incidence we can calculate. Ethically very safe. Here, why it is safe? Because we are not doing anything, we are just observing them, okay? So it means we are not harming them, we are nothing like benefiting or harming, nothing, we are just observing, okay? So ethically this is very safe. Then we have the best type of the design for studying prognosis. Prognosis, do you understand prognosis? What does it mean? Galat said, you are the only person who said. Yes, in simple words.
Like for
yeah, it's
watching the progress.
Yeah, the progress or the consequence or the outcome, okay? The end of a disease. End of the disease could be prognosis is the chances of death, occurrence of death. We use this word actually for the doctors like this. In the clinics, when the patient asks the doctor, what is my prognosis? Like for example, if a patient is diagnosed with a cancer, lung cancer, he will ask you what are my chances of survival, for example. So he is asking you for his prognosis. Okay, how many years I am going to live? Like that. Okay, whatever outcome is. Like this is an extreme example, of course. Okay, so prognosis is like like she said, the progress. How will you progress? How much time do I have? Or what will be the outcome? Okay. So here, on the basis of this design, study cohort study, you can study the prognosis, because here you have followed them, and see the like I have given you the example of the smokers. Maybe I will not just follow them till they develop the lung cancer.Maybe I will follow them till the outcome occurs, any outcome, till some of them were cured or died or recovered, whatever. I want to see the outcome. Maybe this is my study. Okay, so it means through this study, I am myself a witness that this happened. So prognosis, for the prognosis, this is the best study, and because it goes forward in time. Okay, and you can observe it, and you have the evidence strong for the. Okay, so now there are certain disadvantages also. It's not like only goody, but there is something bad about it. Okay, the bad thing is it's very expensive. It needs money, a lot of money. Why? Because we have to follow the people for a longer duration of time. You have to visit them again and again, and it's not just you; it's your team. Okay, a lot of people have to go. So you need the convince, you need to recruit the people. A lot of things actually, and sometimes the time is also a cost actually. So this is very expensive. Second reason why this is expensive is you need a very large sample size. Why you need very large sample size? Because if you need to follow the people for 20 years, 30 years, the chances are very high that some of them may die during that, right? Some of them may migrate to some other country maybe. Okay, you are unable to follow them. Or some of them, they will just refuse to go with you, further. Maybe if I visit them after 2 follow-ups, they just refuse due to any reason. So it means we have the loss to follow. We call it loss to follow. Okay, so certain people, most of the time, we have the loss to follow problem in this cohort studies. So that's why we take large sample size, so that even if we will lose some of them, we can conclude to a statistically significant result. Okay. Otherwise, our result will not be significant. All our effort, our money will be wasted. Okay. So we take a very large sample size. Okay. Time consuming, long follow-up period. Okay. So this is not always possible to follow a study for 30 years, 40 years. That's why So even the investigators, they don't survive. So not efficient for low incidence or rare diseases. Rare diseases you will not go for this design. Why? Because for example, if you want to see a very rare disease like CJ disease, Jacob something, is a very rare disease. Okay, so if you want to see in certain exposure, in certain group, whether they will develop that rare disease or not, the chances are very low. Because like I told you, every exposure has multiple outcomes. So maybe the reason could be, for example, some of the people who have a potential to develop that disease, you lost them in the middle, lost to follow. Okay, and only you are following only those people who will not lead to that disease. Who knows? Okay, so all at the end of the study you will get none. No person develop that disease. So it means this is not an efficient way to choose this disease if you know that disease is very rare. What you can do is for the rare exposure, you will always choose the cohort study. Okay, for the rare disease, you will never choose it. Okay, this is the vice versa. Okay, rare exposure, cohort is efficient, but rare diseases never. Okay, so non-response on migration bias, I already told you, loss to follow. Okay, so some of them will be migrated, some of them will not respond. Can never be assumed to be free of confounding and bias. Confounding and bias, you have a full-fledged lecture with Prof. Manel. She will explain it well. But here, I can just tell you in what can I say? Bias is everything about the design and how you executed the study. You can say in simple words, okay? What type of analysis you, if something is wrong with the choice of the study or the execution, how you did it, or the analysis, this can produce the bias. Okay, confounding is basically a third factor which is impacting your study. For example, my study is about smokers and lung cancer, but at the end of the day, you will get the lung cancer. And you will conclude that it is because of the smokers, but in fact it is not by the smokers, because most of the smokers were also drinking coffee, for example. And the disease may be because of the coffee, not because of, and you didn't know. So the conclusion was true, but it was not because of your exposure of ingredients. So that is confounding. She will explain it, okay? So it means bias, the results are not true, you can say. What you concluded are not true because your execution, your design, your execution, your analysis was poor. Okay, but here the confounding, the results are true, but those are not because of the thing which you were observing. Okay, you can say in simple words. She will tell you. Okay. So identify cohort study characteristics. Identifies the cohort of exposed and unexposed. The four things we know. Cohorts are followed forward in time to assess the incidence of the disease we know. Most cohort studies are prospective. Cohorts are identified in the present and followed from the present to forward, I told you. Okay? It's in the future, starting from present till future. Okay? But there are some of the studies which are retrospective or historical. Okay? Most of the time they are prospective. But we do have certain another type within this, which is called retrospective. I told you, I'll tell you how is it possible, okay? Because the concept is we have to start from the exposure in any way, okay? So how will we do it? Subjects with or without the risk factors were identified and followed up at the later date, but the follow-up date was in the past. And now I'll tell you how. The half of the things okay. At least, okay, so for example, this is the prospective study which is very clear. We are starting today and we will follow them up till the 2030 and 2040. Okay, that's very clear. This is prospective study. This is forward in time. We are starting with the exposure, ending with the outcome. Okay, here another study we call retrospective. Now, if we are interested. Like for example, we are not doing it practically, but we will ask the people. Okay, we will anyway start from the 2000. Example is same. For example, smokers, non-smokers. Okay, we will identify the smokers who started the smoking in the year 2000. In year 2000. Okay, and how will we identify? We will ask them, of course. Okay, or we will get it from the hospital data. Whoever. So that cohort we will identify with all the smokers in Uneza, and then we will follow them up back in time. Again, we have to rely on their memory or the files, right? Then we are reaching today. It means we are starting backward in time, doing the same thing, starting with the exposure. They never had the disease. They were smokers, right? And till now, after 26 years, we will see how many of them have developed the lung cancer. Okay, from the data, or from their memory, or maybe we will conduct a diagnosis, whatever. Okay, by whatever technique today we will identify. But we started with the exposure. This you have to keep in mind because it will get mixed with another study which I'll tell you. Okay, so this is in the past, but the strategy is same. Okay, that we are starting with the exposure, ending without, right? It will never happen that we will start it with a disease and go forward. Okay, they will be disease free. Okay, we have to identify them. Okay, this thing is clear. Okay, now there is a third thing which we call historical perspective. Now this is also called ambispective. Okay, ambispective common one, which is the relative risk. Okay, relative risk is the ratio that measures the risk of disease among the exposed to the risk among the unexposed. Okay, so our numerator will be incidence rate in the exposed, and denominator will be incidence rate in the unexposed. Okay, this is from, you have seen that 2 by 2 table. So this 2 by 2 table. Okay, and now we have the exposure here, smokers, non-smokers, disease is here, that is the coronary heart disease. Okay, so we can calculate the relative risk by dividing the incidence. This is the incidence of exposed, A divided by A plus B, and among the incidence among the unexposed, we can calculate C divided by C divided. Okay, and dividing both of them we will get the relative risk. Okay, here it's written again, A divided by A plus B, C divided when you will divide it with the C divided by C. Okay, so here the example is given, numbers are given. When you calculated it, you got 1.38. Okay, just to save your time. Okay, so this, what does it exactly mean? Okay, it means the risk of developing coronary heart disease is 1.38 times higher for a smoker than non-smoker. This is exposed, this is unexposed. Okay, so you have compared both of them, and now relatively you are saying relative risk means you are comparing them. Okay, so relatively, you know, the higher risk, there is a higher risk in the smokers as compared to the non-smokers. Now this is relative risk, as the name indicates. I think Prof. Manal already told you the relative risk calculation or the formulas and blah blah. Okay, so this just to make sense of this. Okay, so here, or you can say 38%. Okay, because one is common, because one is like equal. So you can say in percentage, if you want to say it means the risk of developing coronary heart disease is 38 times higher for the smokers than the non-smokers. Okay, and why I said this one, exclude this one for the percentage, because one means equal chance, no difference. Okay, I think this also from told you. Yes. Okay, so no need to explain. Okay, if you forget, you can see this, come back to this table and see what does, if the relative risk is less than 1, what does it mean? Okay, and more than 1, if it's more than 1, of course it's a risk factor. If it is less than 1, we call it protective factor, and equal to 1, we will call it no difference. So here is an example, famous example of the cohort study. We call it Framingham Heart Study, which was about the cardiovascular diseases. They studied, they followed a cohort over a time. Real study, you can study, link is here. If you want an example, you can see. Okay, then another example is here, Fels longitudinal study, was about you know, some diseases in Ohio. They followed 5,000 people. Okay, so these are the real studies examples which you can see if you want to see the real studies. Okay, so here we are done with one type. Okay, out of 3. So is it clear about the cohort?
Yes.
Okay. So now this is the second type of observational study. We call it cross-sectional study. Okay, cross-sectional study is the study that examines the relationship between disease and other variables of interest as they exist in a defined population at a particular time. In particular time means they both are present at the same time. I told you for the cohort study, exposure is the starting point, and it goes to the outcome. It means they are not present at the same time, right? We are starting with some and going to other time. So it means they are not present at the same time, right? Here the cross-sectional, both of them are present at the same time. You will find the exposure and the outcome at the same time. So we call it cross-sectional. Cross-sectional, you understand? In the laboratories, labs, you do the cross-section of the something. So cross-section is like cutting something from here, not longitudinal, it's horizontal. Okay, so here it makes sense, horizontal, because both of them are present in present. Okay, at the same time, simultaneously. So cross-section means if we take a cross-section, we will get both things together. Okay, so here best for quantifying the prevalence of the disease or risk factor and for quantifying the accuracy of the diagnostic test. Okay, because here prevalence, how come? Because we can go to any community and just conduct a survey. Most of the time this case control is in the form of the surveys. Okay, We go there, we just find out how many of them, like in the people of UNESA, how many of them are suffering from hypertension, right? I'll just go today and I'll get the data. Okay, on the basis of the data, I can quantify how many of them. Okay, so magnitude of the disease I can identify very easily. Okay, okay, and the diagnostic test also. Like for example, I have 2 diagnostic tests. I want to know which one is better. Okay, what will I do? I'll just implement it in the patients. Like for example, if I have 100 patients, 50 and 50, I'll not implement it. I'll just go to the hospital because this is observational study. I'll do nothing. I'll just observe. Okay, I'll go to wherever the people are taking their test, and then I'll see how many of them are taking this, and how many of them getting which test is getting the correct diagnosis. So I can compare, right? And I think Rohman already told you in Dubai too, sensitivity, specificities. Yeah, that's you can calculate the sensitivity, specificity here by the cross section. Okay, so here simple diagram. Subjects are selected for the study, and we will just see the how many with outcomes and risk factors. All of them can be identified in the same time. I'll tell you how. Okay, example I'll give you. Okay, I think in this slide. Yeah. Okay, so a snapshot of the health status of the population at a certain point in time. Surveys, I told you, you can do it through surveys. Snapshot is like a picture, taking a picture. When we take a picture, everything comes in one picture at one point in time. One picture means one time. It represents certain time. Like I clicked a picture yesterday, so it represents it was yesterday, one day. Okay, one point in time. So the snapshot studies or the cross-sectional studies or prevalence studies is the same thing. Okay, if you find these words, prevalence study. Prevalence study is always is cross-sectional. Okay. Third thing is, if you will find a snapshot study, it is always this cross-sectional study. Okay. For each subject, exposure and disease outcome are assessed simultaneously. Compare the prevalence in the person with and without exposure. Okay. Now here I'll give you the example. Like for example, if I conduct, for example, in my mind, I want to see is there any association between obesity and diabetes. Okay, I want to check. Okay, and I have chosen this cross-sectional study. I could have chosen this the prospective study and follow them over a period of time, but I don't have budget. Okay, I don't have budget to see and to spend. I don't have time to wait for 10 years to see the obese people are developing or not. Okay, so now this is the quick way. I want to see is there an association or not. Okay, what will I do? I'll just find out in I didn't tell you the population. Okay, in the UNESA. Okay, I'm interested in UNESA population. Okay, so what I will do? I will just go and find out the BMI of everybody. Okay, all people, and also will see how many of them have the diabetes. Okay, 2 things I will just get data about these 2 things, and then I will see how many of the obese people on the basis of the BMI have the diabetes, right? If more people have, more obese people, for example, have the diabetes as compared to the lean people, the non-obese people, then I can say that there could be some association. Even though I'm not sure, but there could be. You got my point? Yes. Okay? Why am I not sure? Yes? Clear what? Yeah, it's clear, but why? I just want to know. Because I got the data. On the basis of the data, I am saying that more obese, since I have found more diabetic people in this obese as compared to non-obese. I think, my conclusion would be it's likely that there is an association. Why don't I say there is an association? Maybe there is other reasons. Maybe there are other reasons. So why am I not sure exactly?
Because it's a bias.
What type of bias? I have chosen the study, I have based on the data, which bias I have.
I didn't observe them for the lecture.
Yes, I haven't observed it. I haven't seen it developing in front of my eyes. I don't know whether the obesity led to the diabetes or diabetes is leading to the obesity. On the basis of the data, it's just one thing which I can see in the obese. All the obese, not obese, most of the obese people have the diabetes. Now, how can I say which thing led to which? Which is the cause, which is the effect? The egg and chicken dilemma. Which came first, egg or chicken? Can you say? Nobody, okay? That's because we haven't seen when the first egg was created or the first egg was there. Who was, we were not there when the chicken was made, okay? So since we haven't seen the first chicken or the first